I call to order this meeting of the Oversight Committee meeting. It is precisely 09:01 hours. Ms. Payne, please proceed with the roll call.
Dr. Cummings,
Present.
Mr. Margot, Dr. Hernandez.
Present.
Mr. Montgomery,
Here.
Dr. Patel,
Yeah,
Dr. Rice,
Listening in.
Dr. Rosenfeld.
Here.
We have a quorum.
for the record, Dr. Cummings is joining us via video conference today. This is an option permitted by the Open Meetings Act, and he will count towards our quorum so long as we can see and hear him. We will not be able to count in Dr. Rice, but he can certainly attend. We rely upon CPRIT's IT team to make this work very well and smoothly, and we appreciate them greatly. Members, you have the draft minutes from the November 16th Oversight Committee meeting in your agenda behind tab 1. Are there any corrections to the minutes as circulated? The chair will entertain a motion to approve the minutes of the November 16th Oversight Committee meeting.
So moved. Second.
All in favor, aye.
Aye.
Any opposed? None. Motion carries. Our next agenda item is public comment. Texans created CPRIT. Opening our meetings with public comment underscores the board's commitment to transparency and accountability. Ms. Doyle, has CPRIT received any requests to provide public comment?
No, sir.
Thank you. Mr. Roberts will proceed with the CEO's report.
Thank you, Dr. Patel. First of all, I'm happy to recognize that we have received a donation from the Travis County Emergency Services District Number 12. Quite a mouthful, maybe a longer name than ours as an agency. They held a Fire Up for a Cure fundraiser in October and have provided the funds to CPRIT to use for patient services within our prevention program. We've invited Cassidy Booth, their public information officer, to attend today's meeting so that we may recognize them for their part in our fight against cancer. Cassidy, would you stand up and be recognized and show the t-shirt? Isn't that great?
Ms. Cassidy, please accept the Oversight Committee's profound gratitude for your team. We appreciate everything that you do as first responders. Thank you very much.
All right, the next topic I have to discuss with you will take a minute or two. The grant awards that are available, as shown in the first attachment. If you approve the proposed academic and prevention awards today, that total some $91 million, we will have $122 million remaining for awards in FY 2023. That's not the problem. However, in attachment 2, we'll show you the situation that we are in. It appears that all 3 programs are fully subscribed for the remainder of the fiscal year. Chief Product Development Officer, Dr. Ken Smith, will discuss plans for bringing the Product Development Review Council's recommendations within the balance of funds available. But on page 2-4, an Excel spreadsheet, I live life on Excel spreadsheets. Staff is aware of that. It will show you what has been committed to date, what is expected today, as well as what we think is coming down the pike. As it stands now, academic research has $6.4 million possible for the remainder of the fiscal year. Product development, if we were to fully fund the projects as recommended by the Product Development Review Council, we'd be short 24.6 million. in the funds that have been softly allocated to that program. Prevention, you can count on all of that being very close to zero. And again, Dr. Smith will talk to you all about how we are going to address the demand in product development. This is a good problem to have, and I've mentioned this to you folks on several previous occasions. We were not satisfied with the number of quality product development awards that we're being able to get through the rigorous peer review process. As we've discussed at previous meetings, we've done significant overhaul of the processes of that program. I've been able to bring in some new staff that have been extremely aggressive in their outreach efforts. And that is a good thing. But on the other hand, we now want to be careful about too much outreach and creating demand that we won't be able to satisfy. Obviously, if we get everybody excited about applying for a grant and then we aren't able to fund, it's creates a problem of itself. I view this as an indication of the maturity of all three programs. I think we've got them where we want them to be. Similar situations are happening with the National Cancer Institute. And as we go forward in the next few months, getting ready for next fiscal year, and especially as we start developing program priorities for 25 and 26, there's going to be some serious policy decisions that we're going to have to discuss. Because I do not foresee the demand for these programs decreasing. Some topics that we'll have to consider is higher pay lines for the programs, which is what NIH and NCI frequently have to do. We will have to go into perhaps negotiating budgets more than we have previously. We may have to limit the number of recruitments for one example, or limit other mechanisms, or stagger the times that we release the RFA mechanisms. I know that this can cause some concern among potential grantees out there, but it's fact of life. I mean, we have a limited amount of money. I once said, as a former state budget officer, that $300 million a year sounds like a heck of a lot of money, but boy, you start getting institutions of higher ed and prevention organizations involved, companies involved, it goes pretty darn fast, as you're aware. So just want you to know, and again, you will hear more when Dr. Smith does his presentation. Personnel, since these books were printed, we have retained a new product development program manager. So as I sit here, 42 of our 44 full-time equivalent positions are filled. Again, this is a very exciting position to be in. We are in the process of hiring a technical writer and a grant compliance specialist position. In November, I reported that we had a new program manager, and I'd like to introduce Carlton today. He was unable to be here in November, but Carlton Allen, if you'd stand up. He's in addition to, I guess, both prevention and academic research. You kind of blend across. So I think as I sit here today that we stand in good stead with respect to our staffing. You have all been given the link to the 22 annual report. Again, it is done exclusively online. It has been distributed per law to all 181 members of the legislature and the governor. This is an enormous undertaking that you don't hear too much of it throughout the course of the year, but it takes about 6 months of solid staff work. ably directed by Kristen Doyle, but also other members of the staff, especially Mark Leffler, Justin Rand from the communications team, technical writer Bridget Barstow, our IT folks, Shannon Cusack, the IT designer Royce Hart, all need to be recognized for their work on that report. And I've heard nothing but positive comments with respect to it. The legislative update, since this book was printed, we have found out that we will be testifying next Tuesday to the House Appropriations Subcommittee on Articles 1, 4, and 5. I think I have that right. And it will be a short presentation, and we will see how it goes. January 30th, Heidi and I did present our budget request to the Senate Committee on Finance. It was an odd hearing. It was one of the oddest budget hearings I've had since being at CPRIT, in that that was the day the ice storm was coming in. And so they were rushing everybody to get through. And my presentation wasn't, but and I do time this stuff, 2 minutes and 15 seconds. I had to squish it down to about 30 seconds. Primarily the request is thank you for what's been introduced in the bills. They gave us a very excellent starting point, but it was a little concerning that the only questioning we got had to do with how little revenue we have brought in through our programs. And I know that when you compare our revenues, which today stands right at $8 million, compared to our annual appropriations, it doesn't sound like much, but you folks know that from the time an idea leads the workbench in a research lab and has to go through the FDA approval process, can be 15 to 20 years. It took Jim Allison, what, Kristen, 18 years from the time his product left his bench to when he got final clearance for it. And it just takes time. And I was prepared, I'm always prepared to explain why it takes so long, but they didn't want to hear it. They just expressed distress that we were not a good investment. And we are, as you folks know. I mean, the benefit that the state's economy gets from CPRIT is well documented through the Perryman reports. The benefits to patients through the prevention program is well documented. The powerhouse research institutions that we've helped expand speak well to the state of Texas. So I just say that, I am more accustomed to what a great job you folks are doing as opposed to being criticized, but so be it. Lastly, not lastly. So they criticize us, but at another hearing in Senate Finance, Senator Nichols at the coordinating board's hearing cited CPRIT as an example of the way the coordinating board ought to do their grant programs for revenue sharing terms. So go figure, you get patted here and you get whacked here, but so it goes. Lastly, per law, I provided in the meeting book the report on progress and continued merit for the 22 research program. I encourage you to take a look at this. There's a lot of really good information in that document. I use it through the course of each year as I go around and talk to people. It's a very nice encapsulation of what we have done. Again, documenting the value that we provide. I believe that's it, Dr. Patel. I'll try and answer any questions that you folks may have.
Thank you. Are there any questions for Mr. Robst?
I just have comments. I think you
Please.
guys do an exceptional job as an organization. And when I read the statute, you were created to be an economic engine to create revenue for the state. So there's a little misalignment there.
That's
But you
correct.
do wonderful things for patients and for research, and that's what you're designed to do. And you also have a tremendous impact economically wherever you put your footprint in, wherever you invest as a organization. The state of Texas reaps its rewards from there. So I wholeheartedly disagree with those comments that, 8 million, well, that's not what you were designed for. It's the other way around. And I think you guys, CEO, but also your team as a whole is doing a phenomenal job, and that you're right on par. And really that we should be asking for more revenue from the state, because we are a success. We are a great model for the state, and we are saving lives. So I just wanted to make that comment to you.
Thank you for that. I agree.
Well said, Dr. Hernandez. I'm sure the rest of the Oversight Committee and I in particular join you in those comments. If there are no further questions, the chair recognizes Mr. Burgess to present the Chief Compliance Officer's report. I must say, before he presents his report, that what he does and what his team does is quite extraordinary also. I never, I used to look at you and say, this is going to be horrendously long, but I was wrong clearly. And I apologize for those thoughts, because you're very, very important.
I'm sure you're
Make
not the
sure
only
that
one.
we are on the straight and narrow. Thank you.
Thank you, Dr. Patel, Oversight Committee members. I appreciate you and your support. My report is behind tab 3, and I will be brief. I know we have a lot of other equally important things to talk about today. On page 3-1, with great sadness, I report to you that we're well above our 5% threshold of reporting, delinquent reporting this time around. We shoot for the 5%, which is about 28 reports. At the end of January, we had 45 of those that were outstanding. So we looked at the data, and the data is telling us that of our current active grants, a majority of those reports that were delinquent were due at the end of December. They were matching compliance certification forms. And so it's kind of, loaded into one quarter, 40%. And then you've got academic institutions with time off, vacations, holidays. And so it sort of was the perfect storm at the end of January. But good news, we met this week in our regular weekly meeting, and that number is back down under 28. So I'm happy about that. Again, that's a self-imposed threshold that we have. No need to sound the alarm, but I did want to report that to you. It's not all roses in compliance. The other item I wanted to mention is on the bottom of 3-2. We do require annually for our grantees to submit an attestation form. It's a form of a checklist. And in it, we require them to acknowledge they have certain policies and procedures in place, certain internal controls, and as of today, I think we're still waiting on 2 grantees to submit that attestation. And those are 2 product development grantees. And we're also working with them on, I think, 8 different grantees on Texas location criteria. As you know, that is a requirement for product development grantees, and they're required to submit annually documentation to prove they're actually in Texas. And so we're actively working with 4 of those grantees. Lots of trainings this past 3 months, mostly product development, new grantee trainings. And then we have a new a calendar year grantee training scheduled in March. And that'll be one of 3 opportunities for grantees to meet that requirement. And that's my report. Happy to answer any questions.
Thank you. Any questions?
Vince,
Mr.
the
Narco?
end of the year issue. Is that a deadline that we have imposed on grant recipients? And would we be better off moving it to November or another month, given year-end issues?
So that's a great question. So it depends on when the grant started. And so this is the matching is due after the 4th quarter FSR. So we could have the same discussion 3 years from now, and our active grants could be ending, the majority could be ending a whole different quarter than this quarter in November. So
So
the
you have a 3-month
matching,
leeway within that quarter.
correct.
So
So you,
you could avoid the December, you might have a better response.
well, the matching certification is due 30 days after the FSR. And it's, we used to allow them to submit sort of out of order, but that created a lot of extra work and inaccurate information. And so really, once that fourth quarter is due, then 30 days later, the matching certification is due.
If are there any, Dr. Hernandez?
I wanted to comment what
Yes.
he's saying. Since it's our program, I mean, I understand what you're saying, but if I wanted my data prior to that, I mean, we set the rules. So even if I asked them to do, just to consider, right, and an audit, like I have my CPA, even if I have to get an audit and it's just 1 month worth, it's okay. But at least everybody knows that I have to turn everything in early in October, September, whatever month. That's what Mayor D is getting at, is that you have all the data up front and they get used to it. And now it's part of our procedure. So we always have what you need to get things done in a timely fashion and not be compressed at the end. So it's just something to consider. I understand that you're waiting for your fourth quarter data or 3 quarters. I understand that, but that's something internal that we can change if it benefits you to get the data earlier. So it's always consistently in September or October, whatever it is. Just something to consider.
Yes, and absolutely. I'm just the enforcer of the rules. I don't make them. So I'll defer to Heidi and Kristen on that. Also, when we say an FSR is due at the end of November, they can submit that anytime in that 90-day period. So that is for expenses for the previous quarter.
I know, but human nature is that everybody waits.
Yeah,
Right?
absolutely.
As an account, right? We all wait to the
Yes.
bitter end. That's
Yeah.
just the way we are. It's human nature.
Yes. So I don't know if Heidi or Kristen have any additional comment on that.
But needless to say, thank you.
Thank you.
Now turning on to the certification of the award slates that we will consider today. Mr. Burgess will provide the compliance certification report for the academic research and prevention programs awards presented today.
Thank you, Dr.
Please.
Patel. You'll find my compliance certification in your proposed grant award booklet on page 81. And my memo is dated February the 3rd, and it was made available to you in the OC portal. In my certification, I outline every step in the peer review process and my review of the pertinent documentation, support documentation provided by our third-party grants administrator and CPRIT staff. I also attended the PIC meeting on February the 1st and certified that process follows CPRIT's rules. I'll note, and I trust that Dr. LeBeau and Dr. Smith will also speak to the deferrals that were agreed upon in the PIC meeting. And again, that process complied with CPRIT's rules. So I've reviewed the supporting documentation and I'm satisfied that the review process was followed, and I certify these recommendations for your consideration this morning.
Are there any questions? Hearing none, thank you, Mr. Burgess.
Thank you, sir.
The chair recognizes Dr. LeBeau to provide the academic research program update and introduce the program integration committees or the PIC committee grant award recommendations. Dr. LeBeau.
Thank you, Dr. Patel. The Scientific Review Council recommendations for FY23 review cycle 1 and recruitment cycles 23.2 and 23.3 include 65 awards from 8 grant mechanisms. Whoop. And you see those on the left side, the columns on the left side of that slide. These recommendations totaled just over $105 million. But as Mr. Roberts previewed for you earlier, The SARC recommendations exceed of it, thank you, available funds that the academic research program has. And the Program Integration Committee therefore voted to defer action on 25 individual investigator research applications that total just over $28 million. And these are the applications that scored 2.8 and higher. So you see the PIC recommendations of 40 awards and award funding of $77 million, and that is shown on the right columns of this slide. Yes.
Are the grants listed in table 3 the ones that were funded and deferred, or just the ones that were funded?
So we provide you a list. The first table are the grants that are recommended for funding. The second table for each award. So for example, table 3 are the IRA awards that are recommended for funding. Table 4 follows it, and those are the IRA awards that are recommended for deferral. And then you'll see 2 tables for each of the IRA mechanisms. You'll see 2 tables then for the next mechanism.
Thank you.
Michelle, deferral means we just don't have enough money, or they didn't score well, so they're not going to be funded. What does that mean, deferral?
These mean that they scored well enough that the Scientific Review Council recommended them for funding.
Yes, ma'am.
But because we do not have sufficient funds to fund them, that we are recommending them for deferral.
Thank you.
Any further questions? First, we will take the award recommendations, then we will vote.
So why don't I go through them?
Vote for the
Okay.
first. Oh, well, I thought,
Moving right along.
That's fine.
I tend to go ahead of myself, sorry.
Okay. The priorities addressed by the recommended awards are shown here in table 2. And I'm pleased to say that each of the academic research program priorities are covered by these awards, and including some of our high priority areas such as childhood cancers and computational biology. If I just go very quickly through the individual IRA awards, the IRA, the SRC recommended supporting 37 individual IRA awards, but due to limited funding, PIC recommended funding 18 of these awards, totaling $18.8 million, and deferring 19 awards or higher to August of 2023 should any funds be available to support funding these. The next slide shows the IRA recommendations for cancer in children and adolescents, the recommended applications, and the Scientific Review Council recommended 8, and PIC has recommended supporting 5 and deferral of 3. And I'm pleased to say that the recommended awards support a nice range of projects, including research on very high-risk tumors such as hepatoblastoma, gliomas, and leukemia. The next slate is the IRA for computational and systems biology, and the PIC has recommended supporting 3, which are shown here, and deferring 2 awards. The slate for clinical translation is shown here, and PIC has recommended funding 1 and deferring 1 award. And the last slate is the slate for prevention and early detection. And for PIC has recommended supporting 4 awards, and these represent all 4 awards that were initially recommended by the Scientific Review Council.
Now I can say, are there any questions?
Okay. I'm happy to go ahead and present the remainder of the slate, which is the TREC awards
Please do.
and
Thank you.
the recruitment awards. The next slate that I'd like to present is the slate for the Texas Regional Excellence in Cancer Award recommendations. And the SRC and PIC have recommended funding 3 of these awards. And these are really seminal awards that allow institutions to help build infrastructure, recruit faculty, and advance their cancer research programs. And these awards are designed for institutions that are located in regions that are at least 100 miles away from NCI designated cancer centers and typically have received lower levels of peer-reviewed support from national agencies for cancer research. The first award that PIC has recommended is the TREC Award from the University of Texas, Rio Grande Valley, submitted by Dr. Chauhan. And this award proposes to establish the South Texas Center of Excellence in Cancer Research, which will develop an integrated approach designed to reduce cancer health disparities in this region. And they seek to define the etiological and lifestyle factors that affect the development of cancer and seek to reduce the impact of these cancers on the community. And importantly, they will focus on hepatocellular carcinoma. The second award was submitted by Texas Tech University Health Sciences Center at El Paso and proposes to establish the Impacting Cancer Outcomes in Hispanic Center led by Dr. Lakshmana Swamy. And he is proposing to leverage the institutional's investments and strengths in cancer research and to reduce the community impact of cancer through improving the knowledge of the biology, cultural, and behavioral determinants of cancer, and by developing new therapies and biomarkers for cancer. And they are focusing on cancers that are also critical and in West Texas, and that includes breast cancer and leukemia, but also proposing to develop targeted therapies for breast, pancreatic, and liver cancer. The third track was submitted by Texas A&M University and is led by Dr. Kenneth Ramos. And this award will take advantage of, will take advantage of the resources that are available to Texas A&M. And they are focusing on studying how biology and genes are modified by lifestyle factors to influence cancer risk and cancer development, and how to effectively use this knowledge to increase precision in cancer prevention and healthcare delivery. So that concludes my presentation of the TREC Awards. I'd like to move to the recruitment awards. And we have 6 awards that are recommended for your consideration. The first are 2 recruitment of established investigator awards. The first is an award is for Dr. Hongfang Liu, who is nominated by UT Health Science Center at Houston and is currently located at the Mayo Clinic. And she is being recruited to become a professor and director of the Center for Translational Artificial Intelligence in Medicine. And she is an exceptional bioinformatician who has pioneered machine learning and artificial intelligence techniques for natural language processing of clinical data and biomedical research data, and using this data for healthcare delivery. And of course, her emphasis is on cancer. she has developed a very large project called the Wonder Project, which aims to accelerate the use of real world data driven oncology research through the use of data science and informatics to study longitudinal patient records. The second nominee is Dr. Rudy Fasson, who is being nominated by the University of Texas at Dallas, and he's currently located at the University of Rochester. And he's being recruited to become a professor and endowed chair in natural sciences and mathematics. Dr. Fasson is a world-class synthetic chemist who has focused on the design and application of new biocatalytic and chemoenzymatic methods for the discovery and development of biologically active molecules. And what he's proposing to do is to use the novel enzymatic strategies that he's developed to synthesize and modify complex natural products, and to use these libraries to discover inhibitors of protein-protein interactions, which are an important class of cancer drugs. Moving then to the 4 first-time tenure track faculty members that have been nominated. The first is Dr. Kenneth Hu, who has been nominated by UTMD Anderson Cancer Center coming from the University of California, San Francisco. Dr. Hu is a cancer immunologist, and he is coming to the Dr. Jim Allison's department and will be mentored by Dr. Allison directly. Dr. Hu studies well, let me backtrack and say tumors are composed of spatially heterogeneous mixtures of regions that are responsive and non-responsive to immunotherapy. And at the present time, how interactions between cells that are generated by this landscape and how immunotherapy interacts with this landscape is not well known. But Dr. Hu believes that and proposes to elucidate how immunotherapies interact with that landscape. And he will, and to use that information then to define cell-cell communications and to use this information to define new therapies. And he will use new state-of-the-art technology such as spatial transcriptomic analysis and high-plex imaging to study tumors. The next applicant is Dr. Joan Nassour, who was also nominated by UTMD Anderson Cancer Center and comes from the Salk Institute. But I should mention that MD Anderson has withdrawn this nomination because the applicant has accepted another position. So I'll move to the next candidate, which is Dr. Lu Wang, who is being recruited to UT Health Science Center at San Antonio. Dr. Wang is a very exceptionally accomplished junior investigator, and she has expertise in defining epigenetic mechanisms, specifically in those mechanisms that are involved in carcinogenesis, in aging, and in embryogenesis and stem cell function. She's now proposing to focus her work on elucidating how aging-related changes in our epigenome, in our DNA's epigenome, affect the development of non-alcoholic steatohepatitis and hepatocellular carcinoma, which of course is a major health burden in the UT Health San Antonio catchment area. And I'm really delighted to say that she brings with her a very prestigious NIH K99 R00 Pathway to Independence Award. The last nomination is Dr. Ewan McCrae, who is coming from the Methodist Hospital Research Institute, being recruited by the Methodist Hospital Research Institute from Cambridge University. Dr. McCrae is one of a small cadre of scientists studying RNA biology and as treatment for cancer. And he's developed a very powerful pipeline for generating designer mRNA molecules. And he wants to exploit the differences in the proteins, meaning the mutated proteins that are present in cancer cells, such that these proteins differentially interact with the designer RNAs that he has developed and introduced into cells that result in specific cell type specific expression. And he'll use this strategy to develop mRNA therapies to selectively kill breast cancer cells. So that completes the slate of applicants and awards. I am happy to go ahead and also present the 5 new RFAs that we are seeking approval for as well.
Please do.
Okay.
Thank you.
We are seeking to repost the individual investigator research awards, and we have 5 different IRA awards. All of these awards address critically important questions that significantly advance our knowledge of the causes, prevention, and or treatments of cancer. The first is the Individual Investigator Award, which is investigator-initiated basic translational research in cancer. The second award is a IRA award that is focused on computational and systems biology of cancer that you see at the bottom of this slide. The third IRA is focused on a key area, which is cancer in children and adolescents. The fourth IRA is focused on cancer prevention and early detection. And the last IRA award is focused on clinical translation and supports clinical trials.
Thank you. Any questions?
I have a question and comment
Yes.
out of, Michelle, of course, our great illustrious CEO, thank you for this great slate. It's amazing, again, the amount of research being done in Texas. And I'm so happy that we're supporting all this organization. And, one of our priorities has been always we're not immortal. All of us, including CPRIT, it's not going to be here forever. And I'm so proud of our committee and our leadership that we need to push out and make sure we take care of all of Texas. And you guys have done an amazing job of putting out and trying to help out the organizations outside the traditional research belt. And it's very evident in cycle 1. I mean, you're issuing almost 77 million and you're giving UTRGV, Texas Tech and El Paso and A&M, the rural areas that desperately need your assistance. And you recognize that and you're giving over almost 23% of cycle 1 funding to them, which says a lot about your commitment to the state of Texas as a whole. And I just want to acknowledge the fact that I want to thank Wayne and everybody, and especially the committee, for that commitment to take care of all of Texas, and we will reap the rewards as a state. So Michelle, congratulations to you, and of course, Wayne, for our illustrious CEO, who's always so quiet. Thank you for your leadership. And I know this is very important, of course, to our committee, especially Mayor DeMarco as well from El Paso. So thank you.
Thank you.
Any further questions? Will? No? I'm surprised.
Well, I can think of something if you really want me to. No.
Yeah. First, we will take up the award recommendations and then we will vote on the 5 requests for applications. Mr. Burgess has certified compliance for the research and award process. It is my understanding that Dr. Rosenfeld has reported a conflict with one proposed academic research award recommendation and will recuse himself from the vote. Are there any other conflicts of interest? Seeing none. Members, you have the list of applications and grant amounts recommended by the PIC for the academic research grant awards. We will approve the PIC's recommendations if 2/3 of the Oversight Committee members agree. We will first take a vote on the application that Dr. Rosenfeld has recused himself from considering. I will entertain a motion to approve the PIC's recommendation for Individual Investigator Research Award for the grant application number RP 230344.
So moved.
Second.
All in favor, vote aye.
Aye.
Any
Aye.
opposed? Thank you, Dr. Cummings. Hearing none. Hearing approval from at least 2/3 of the members, the motion carries. I note for the record that Dr. Rosenfeld did not vote, let alone blink. It's much appreciated, old chap. Now we will consider the 8 award slates constituting 39 other grant recommendation in one vote unless the Oversight Committee members wishes to consider the award recommendations separately. Hearing none. I will entertain a motion to approve the PIC's recommendations for the following 8 mechanisms. Recruitment of first-time tenure track faculty members, recruitment of established investigators, the Texas Regional Excellence in Cancer and Individual Investigator Research Awards, including those specifically awarded for childhood and adolescent cancers, computational systems biology of cancer, clinical translation and prevention, and early detection.
So moved.
Second.
All in favor, vote aye.
Aye.
Any opposed? Hearing none. Dr. Cummings? Oh, thank you. Hearing approval from at least 2/3 of the members, the motion carries. I will entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT.
So moved.
Second.
All in favor?
Aye.
Any
Aye.
opposed? Hearing none, the motion carries. Now it's for the approval for the fiscal year 2024 RFAs. Members closing out our action items for the academic research program. I will entertain a motion approving the 5 proposed fiscal year 2024 RFAs as presented by Dr. LeBeau.
So moved.
Second.
All in favor?
Aye.
Any opposed? Hearing none, motion carries. Thank you. The chair recognizes Ms. Maggot. Thank you, Ms. Dr. LeBeau. The chair recognizes Ms. Maggot to provide the Chief Prevention Officer's report and introduce the Program Integrations Committee's grant award recommendations. I wish I could make this simple and just say, please present. It'll make my life
You're
so
the chair.
happy.
Do what you want to do.
Oh, well. I
Good
wish.
morning, members. The prevention program update is first, and it is behind tab 5 in your books. And the main update is the cycle 23.2 applications are due next week. So we're looking forward to receiving those applications, and will be the first applications for the colorectal cancer screening coordinating center. So very exciting. So if there are no questions about the update for now, I can move on to present the recommended projects that the PIC recommended, 8 prevention projects for 13,577,257 in 3 different slates. All of the recommended awards address one or more of the priorities. In this case, all of them address all 3 of the population-based priorities. The awards that I'll now go through can be found on page 73 of your proposed awards book. The first slate is the cancer screening and early detection slate, and there are 4 recommended projects for 9.5 million. The first is from the University of Texas Southwestern Medical Center, Dr. Keith Argenbright. This is an expansion of their very successful breast cancer screening and patient navigation grant. They are expanding again. They are adding 32 counties for a total of 67 counties that they plan to cover. And interesting factoid that they put in their application, it's the geographic area is the size of the state of Georgia. So they're going to do amazing coverage of the state of Texas. They use a centralized reimbursement for all their local providers, which is unique to this project. And they'll be looking at the, doing assessments of social determinants of health to identify barriers to accessing cancer prevention and screening and diagnostics. And these include, health literacy, transportation, neighborhood safety, social support, and community engagement and insurance coverage. The next project is from the University of Texas Southwestern Medical Center, Dr. Jane, and it is an expansion of the hepatocellular cancer, hepatitis C, and they're expanding to cover all adults ages 18 to 79. They will be doing hepatitis B screening and vaccination, and then screening and navigation into treatment for hepatitis C, covering 17 clinics in 15 different counties. The next is the University of Texas Health Science Center at Houston, Dr. Savas. And this is an expansion of their breast and cervical cancer early detection and prevention program, primarily for the Latina population, but of course would not turn others away. This also includes HPV vaccination. And they will be in 36 counties and expanding for the first time to the Panhandle. The last of the cancer screening projects is from the University of Texas Southwestern Medical Center, Dr. Gerber, and this is a lung cancer screening and tobacco cessation project. And these will be patients that are through the Parkland Health System, which is a huge safety net provider in Dallas County, focusing on the population in South Dallas, which has the greatest lung cancer risk and the most pronounced health disparities. If there are no questions about that slate, I'll move on to the dissemination.
I do have a
Oh.
quick question. You said that the South Dallas has the greatest rate of lung cancer in what?
In Dallas.
In Dallas. Okay,
yes.
thank you.
The next slate is the dissemination of CPRIT funded cancer control interventions. These are, they've been funded for, from CPRIT for a successful intervention. And now this is their, they're developing toolkits and providing technical assistance in order to expand to other areas. There are 2 recommended projects for a little less than $900,000. The first one is from the University of Texas Health Science Center at Houston, Dr. Cucaro. It's a dissemination and implementation approach to increase HPV vaccinations, primarily in the schools and in community health centers. And they will provide a toolkit and do training courses and provide technical assistance. And they'll use the ECHO series to prepare implementers for the project. The next dissemination is from Dr. Lorraine Reitzel. This application came in from the University of Houston, but she has since moved to MD Anderson Cancer Center, so that the logistics will take place after today and the contracting process. Her project is a dissemination of her successful Taking Texas Tobacco Free project, and she'll be targeting lung cancer screening programs and training the staff and working on tobacco-free workplace policies, providing education and training for the staff, and also providing some nicotine replacement therapy for the patients there. Any questions about that slate? If not, I'll move to the primary prevention of cancer slate. 2 projects are recommended for a little over $3 million. The first is from the University of Texas Health Science Center at Houston, Dr. Reininger. And she is based in South Texas, but is associated with, they have a campus down there at the Brownsville. Her project is the implementation and evaluation of a multi-level lifestyle intervention for rural populations in South Texas. And she will be providing this intervention to 4 counties, and it will include, you know, physical activity, food choice, alcohol use, and determining the social determinants of health and the needs of the patients there. And she, interestingly enough, she was one of the first grantees from the CPRIT prevention program over 12 years ago now. So this is the first time she has come back to us. And lastly is the University of Texas Medical Branch at Galveston, Dr. Anna Rodriguez. She also has a HPV program in the school system in the Rio Grande Valley. She'll be working in 8 school districts and many schools in Hidalgo, Cameron, and Willacy counties. Are there any questions? Sure.
When you say school system, do you mean public school system for kids in high school, elementary school?
Yes. The public schools.
And would the vaccinations be something offered at the school, or do you need parental permission? How does it work?
Yes, they do need parental permission, so they send, in this case, well, in both the cases of the HPV programs, they have packets of information they send home with the children, and then the parents sign, and the child brings back the consent form, or the parent comes with the child or at the time of the vaccination. Sure. If there are no questions, I can move on to present the proposed RFAs for fiscal year 2024.
Thank you.
These are in your regular program book, page 5.2. There are 4 proposed RFAs, and they are the same ones that were offered this last cycle. There are no substantive changes, just typographical errors being corrected and things like that. But so these are presented for your consideration. The dissemination of CPRIT funded cancer prevention and control interventions, the primary prevention of cancer, and the screening and early detection mechanisms. The Colorectal Cancer Screening Coordinating Center will only be issued if there is no award that is recommended from the current cycle that is due next week. Those are the 4 recommended RFAs. Are there any questions?
Hearing none. First, we will take up the award recommendations, then we will vote for the 4 requests for applications. Mr. Burgess, where is he? Has disappeared. Has certified compliance for the prevention award process. Oh, there he is. Where's Waldo?
Kind of looks like it.
It is my understanding that no oversight committee member has reported a conflict with any award recommendations presented today. Are there any conflicts of interest that members have not already reported? Seeing none. Members, you have the list of applications and grant amounts recommended by the PIC for the prevention grant awards. We will approve the PIC's recommendation if 2/3 of the oversight members agree. There are 3 slates constituting 8 grant recommendations. Rather than taking a separate vote for each mechanism, I will ask for a vote to approve all the recommended awards. If a member wants to consider the award recommendation separately, please speak now. Anyone at all? None. Thank you. I will now entertain a motion to approve the PIC's recommendations for the following mechanisms: cancer prevention and early detection, dissemination of CPRIT funded cancer control interventions, and primary prevention of cancer.
Second.
All in favor?
Aye.
Any opposed? Hearing none, and hearing approval from at least 2/3 of the members, the motion carries. Thank you very much. I will entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT.
Second.
All in favor, vote aye.
Aye.
Any opposed? Hearing none, motion carries. Members, I will entertain a motion approving the proposed fiscal year 2024 RFAs as presented by Ms. Maggot.
So moved.
Second.
All in favor, vote aye.
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 Any opposed? Hearing none, motion carries. Thank you very much
Thank
for that.
you.
Moving on to agenda item 9. I recognize the Chief Product Development Officer, Dr. Ken Smith, to provide the product development program update. Dr. Smith?
Good morning.
Good morning.
My report is on tab 6. We put up the thanks. Do I have control here somehow? These newfangled things. I just don't know what to do. Okay. With my big fat thumb, okay. All right, I'll try it. What if it goes backwards? Okay.
Then you speak backward.
I have trouble up doing forwards. So basically we started in August 24th by posting these 4 RFAs, and these RFAs are different, and I'll kind of go through. We did this last time, but I'll kind of, reiterate what we did last time quickly, hopefully. So the 4 RFAs were a therapeutic, a device diagnostic, a new technology award, and a seed award. And so that was different from the past where we had a relo, and we also had kind of a general award and then the seed award. So in this, we basically were trying to get some companies perhaps that were hesitant to apply to CPRIT in the areas of diagnostics and devices and bioinformatics and some other things that perhaps in the past we hadn't seen as much of. So these are the 4 basically that we'll present again later, for next year, that haven't changed particularly substantively. So the process now, and this is the first time we went through it, is that there was a round of preliminary applications. And the preliminary applications were different than in the past because the preliminary applications only were like 16 slides and a couple summary descriptions of the project. And so this was also provided on a rolling basis so that we didn't have a definitive deadline. So the idea behind that was, 1, make it easier for people to apply. And 2, if we have a rolling kind of, process, then basically it would be more accommodative to the people to apply. Because the goal in many ways, we did the outreach too, we were trying to get more applications in. So once the preliminary applications came in, then they'd be, just scored and reviewed. And then a decision would be made to whether to go forward to a full application or whether to basically give them a summary of kind of why they were rejected at this point in time, and perhaps some pointers as to how they might, refine their application on a reapplication. So that was the first part of the process, the preliminary part of the process. And so we got the preliminary applications. This is the data that we've gotten. So basically, I said we started in August 24th, and I think that we cut off applications right at like the first of the year once we had gone through the due diligence. And so by that time, we had actually received 60 total applications, and 2 were ultimately withdrawn because of the timing of it. So there was a total of 58 that basically went through the preliminary review process. And as you can see, a 50-50 split. So 29 got recommended to move forward, and 29 were basically rejected at this point in time, the preliminary review portion of this. And what was interesting in some cases is to look at, you know, the number of therapeutic applications still kind of dominates the total applications. It was half of the total applications. And then the second number is the seed awards. So we did get some device and diagnostic applications, and we did get some new technology applications, but this is still kind of dominated by the therapeutic side of the equation. Oh, yeah. Yeah, Wayne, you want to try?
With my pudgy little fingers.
I know, I hit the same thing that,
What are you, what are you?
yeah, that. Ah, there we go. What can I say? Why don't you call on to that?
I'm
for me?
IT.
Yeah. All right, so this is the preliminary application data by mechanism. So obviously 21 of the therapeutic companies were invited, and it was based on the score and some after discussion. So in this process, basically the preliminary application process, the mechanism is such that there's a scoring from 1 to 9, and then we had a cutoff, and below that cutoff, basically companies were invited without discussion. Above a cutoff number, the companies were rejected without discussion. But in this kind of netherworld of about a half a point, the companies were discussed, and the panels were comprised of the members, 4 members of the Product Development Review Council. And they were broken into 3 different panels, and every week we get new applications in. They'd be assigned to one of the panels, and then they would decide based on the scores up or down, or whether they would actually have a discussion. And actually, there were, as you can see, there were quite a few discussions. On this slide, there's 11, and on the next slide, there's 12. So out of the 58 companies, 23 were actually discussed. And we had a meeting with the PDRC yesterday, and they all seem to think that this is really a good idea to not just reject companies out of hand necessarily, or to move them along. If they're really kind of interesting, the PDRC members basically get together and have a discussion about these companies. And one of the other interesting things about the way things played out with the preliminary application is that the most we ever got in 1 week was 8, which was kind of difficult to handle in terms of the panels themselves. But typically it would be more like 2 or 3 or 4, which was a nice flow actually for the whole process. And it helped the process, I think, early on proceed. So Wayne, I kind of like this. So you can see here that again, about and this is the ones that weren't invited based on the scores, and then which ones got in after discussion. So like I said, 23 companies were actually discussed. So at the end of the day, after these 58 applications were reviewed, 29 of them were recommended for full application. Now, at this time, unfortunately, I mean, again, there was a timing issue to this too. So that we could do funding, there was a cutoff at November 1st for getting full applications in. And as you might imagine, if you were later in kind of the queue, if you didn't get your application in until mid-September or along those lines, it was difficult, or mid-October, it would be difficult for you to get your application in. And that's why you'll see by November 1st, we only had 14 of the 29 applications that actually got in by the deadline. And of those 14, then we ended up reviewing 10. And part of the issue there was, Glenn, if you can go to the next one. Ha. Oh, one back. Thank you. Right. So part of the issue then was having enough reviewers. So the PDRC reviews in the preliminary level, right? And then they make the recommendations as to whether the full application goes forward. The full application's 80 or 90 pages long. And the process there basically is you get the full application, the reviewers. Now the reviewers, unlike the last process, the reviewers basically were hand selected by both CPRIT as well as people that with a lot of experience on the PDRCs, the chair and the co-chair. And they recommended certain panels, and the panels were about from 7 to 10 reviewers. And ostensibly, were selected to have a particular expertise in a particular area for that particular company. And because of that, as you can see, I mean, if everybody did one application, you'd have to have somewhere between 70 and 100 reviewers to actually look at it. Now, in some cases, I think one reviewer or two reviewers ended up being on 3 panels, but we try not to overburden our reviewers because it's the easiest way to lose them is to burn them out or to make it difficult for them to basically, be able to be part of the review panel. So these review panels are selected, the applications come in, the panel members get the applications, and then they put together a list of questions for the company. Send the questions to the company, right, prior to an interview with the company. So the company gets those questions like a week or 2 in advance. They respond to them by their presentation. So the presentation basically addresses the questions. And the idea behind this is you already know kind of what the company's about. They've done a preliminary review. There's no need for them to go through, all the basics again. And one of the things I liked about this process, the way it played out was the panels really did drill down with the companies during the interview. So instead of the interview being a 30-minute presentation, we're in cancer, it really came down to, okay, what about this? What about this? This is a problem. Let's look at this aspect of it. And so that 2.5-hour meeting actually ended up being kind of I won't call it grilling, but they really did drill down in the companies to make them support, their project all the way down to like, if it's a clinical trial, support, the numbers, support the budget. And so I think that part of the process to me is good. And so because of that, because we knew that we need this many people, unfortunately, of the 14 that got their applications in, we could only do 10. Now, as you'll see, one of the goals of the next round will be to try and improve that to maybe 15, panels. But again, we need to continue to increase the number of peer reviewers we have. We also have to increase the expertise, right? Because again, on the new technology side, you've got bioinformatics, you've got cell manufacturing. It's not traditionally the things that CPRIT has funded, nor are our panels necessarily on the PDRC. Although I did poll them yesterday, and one of them said, "Yeah, I know everything about AI." I said, "Well, that's only 1 out of 15." So we still need expertise in particular areas, and we need to continue to do that to make this process work. And I think interesting on this slide basically is it's still not only is it heavily weighted therapeutic in terms of the number of applications, but the number of ones that get recommended are also, that's the highest percentage. And the rest of them fall far behind except for perhaps C. So next slide, please. So once we got through the 10 applications, basically 6 of those were recommended for due diligence. And due diligence has changed a little bit this time too, because in the past we had a company, Icon, that would do kind of a global due diligence with respect to the companies. And we'd have different people, and a lot of times they were PDRC, that they'd only like 1 or 2 people to go through the due diligence with the company. This time, the due diligence really is the whole panel that did the full review. They also were on the due diligence. We had the company available, we had the IP council available, and we have a third party that we use now that instead of doing kind of a global view of it, they really drill down on things that the panel feels they don't have expertise in, like in particular, like clinical trials. So they looked at certain questions that the panel came up with. So the panel will come up with questions. Some were directed to the company, some were directed to the IP council, and some were directed to this third-party due diligence company. And we also had the third-party due diligence company look at the budgets and try and scrub the budgets and give us a sense of whether these budgets could be reduced. So at the end of all that, we ended up with 6 companies, and they all got through due diligence. So 6 went into due diligence, they all came through due diligence, and the total request is 82 million. Well, the problem with that is the fact that we only have 57 million. So, but getting feedback from the third-party due diligence and their recommendations and suggestions to some extent about how some of the budgets could be cut made us realize perhaps we should be scrubbing these budgets. And if we can do that, and we can actually decrease the amount of money each company has, then we can fund more companies. And that's the goal here, is to see if we can basically get to that point where these companies, And there's a variety of ways to do it, right? The company itself could come up, instead of just 50% matching, they could come up with additional money. You could also do a situation where we've talked about before, we already tranche money, right? But there might be more of a gating mechanism. So we don't want to go, okay, here's a week's worth of money, here's a week's worth of money. But we might go after a year or two, that there's a milestone or a gating mechanism by which, if you get to here, let's take a look and see if you get this much more. So we're thinking about 3 or 4 ways to do this.
Quick question. Are you saying you didn't scrub the budgets this time? You're going to the next time?
No, we're doing it this time.
So
and-
these budgets were scrubbed and reduced to what you think?
No,
we
that,
need-
that's the process we're gonna do. So we're
You
here
were
today
going
to
to do
base,
it.
yeah,
Okay.
we're here
good.
today to basically say, we're gonna push this till May to get approved.
Got
And
you.
in the interim, we're gonna work with the companies to try and get
And-
it down,
okay.
right? Now, the companies are rank ordered, so that if in fact we can't get all that money, we can't get down to 57 million, we may have to only fund 5 companies.
And so you also are basically saying that the truncated process we approved the last time is working on the application side, et cetera.
Yeah, I'm pleased with it. I mean, again, we still want to get feedback, and we've gotten some feedback from the PDRC. I still need to get feedback from the reviewers, but I think the process worked very well. I do. And again, we're still trying to do things to tweak it and improve it, but yeah, I think as a whole,
Ken, do the companies know their rank order?
no.
Okay.
No, and so the companies do know, though, that, they're in the queue for funding. And that, when we told them what the situation was, and I've gotten some feedback from some of the companies, and after today, we'll do it, in earnest. But I've gotten some feedback that makes me think that, yeah, we can probably, I don't know if we'll get to 57, but we certainly, some of them will be able to reduce their budgets in a variety of different ways.
What about feedback from the companies on the process?
Yeah, no,
other
we're in
words-
the process of doing that too. And again, you know how it's gonna go. I think that the good part of it is that it is a rolling process and whatever. The bad side of it is the fact that we have limited funds. And so those 4 companies that didn't get to be reviewed this time, right? They're gonna move forward the next time in the next cycle for the next fiscal year. But there are many, the other 15, right, that were recommended for full applications, they're gonna have to go through the process again. And so that's one of the limitations of having, like Wayne said, 300 million sounds like a lot of money, and of the stuff that the product development, 75 million. It's not what it used to be.
If you were able to fund all these companies with the 57 million, 6 companies, what would be the success rate, either in terms of dollars requested over dollars awarded, or number of applicants, number of awards?
So, yeah, so it would depend, right? So then if we could get, I think we'll get 5. If we got 6, obviously you do 6 over 60 or 5 over 60 to get your number of their actually, if you start with preliminary applications, then you can divide it by any denominator, depending on whether it's preliminary or whether full or whatever. And then you're looking at probably, I mean, the reduction there is about 25, 27% that we'll have to reduce overall. And like I said, there's a variety of mechanisms I think that we can use. But I also think the benefit of this too is it puts, and I was thinking about this the other day, it puts, kind of the companies on notice to really give us your best budget. Although I worry a little bit, they go, now I got to inflate it a little bit more because I'm gonna have to scrub it. So will it be perfect? I don't know, but I think it's a good idea to look at the budgets and try and work with the companies to figure out how they can do this most efficiently. And for CPRIT in a way to maybe have a gating mechanism, even though, like I said, it's already tranched. It may be that you're like, this goal, if you get here and you fail, right, then we're not out another 5, 6, or we don't have to do our mechanism to say, basically, you need to be done.
The total time, from preliminary application to actual approval of the award by us would be 6 or 7 months in this process. Start November 1st, and then it'd be a May approval, assuming you get through the budget thing, right?
Yeah.
How does that compare with how it was before? In other words, has the process speeded up from their perspective?
I guess this time probably not, or maybe a little bit. The goal here was to actually come here today and And if in fact the recommendations had been below $57 million threshold, then your number basically is 3 months shorter. So you're from August to, so it's 5 months. So it would have been, it's just a simple fact that we're trying to accommodate more that extended the process a little further than we would have initially anticipated. And hope in the future, because if we can get this whole budget thing down to more of a, a streamline, I still think the 5 month kind of timeframe is something we shoot for.
Dr. Smith, question from Dr. Rosenfeld.
Ken, so there's no cap on what the potential award could be, is that right?
That's correct.
Maybe, and did we have a cap in the past?
Yes,
That's what I
20 million,
thought.
right.
So the question is, if we're getting more applications and we got to decrease the dollars per application, should we go back to a cap?
There's a couple ways of addressing that. I mean, the idea behind uncapping it was if there was some tremendous idea out there that would bring a ton of jobs and revenue and stuff to, I think as a practical matter, the people that we have as peer reviewers are very skeptical. When you start to get up to 20 million, and we had some above 20 million, they get a little bit, they're like, hey, we're going to give, a third of the money to you guys, and it better be really, really, really good. And so you better have an approved product, I think is what, kind of the way it works out.
Sure.
So, but the other way to do it, and again, this is probably the wrong forum for it, but that's part of the reason that we have the devices diagnostics. If you look at the average, I don't know where that is, but the average request for devices and diagnostics is 5 million less than what it is for therapeutics. And so you can see a realm of which you have, kind of a tiered, not even tiered, like kind of a continuous, you have the seed down on the low end, 0 to 3, and then hopefully a device diagnostics and maybe some of the AI type stuff, because it doesn't require, FDA approval. You might have a spectrum of 5 to 7, 8, 9, 10.
So Ken, do you think reinstituting a cap would be a good idea?
I don't think it's necessary in the sense that I think that our reviewers are so skeptical. I mean, it was 20, right? And like I said, of the 58 applications we got, I think there was 2 that were over that 20 million. So that's the only reason I say I don't think a hard cap is necessary. I think that there's not enough that do that. And again, if someone needs 30 million and it's really a great project, we think about it. But believe me, we think about it hard. I mean, the reviewers would think about it hard.
Hey, Ken, on your proposal here, I'm not sure about the cap, just, I'm not sure I'm sold that we don't need a cap, but going to Wayne's headache earlier, he mentioned about the legislators and the economic impact that we have revenue wise. CPRIT is designed for the research. However, we do have an economic impact, and I don't know if you have thought about this or we're allowed, but we should, if I'm going to put something in Dallas, for instance, by a grant, it's great. It creates jobs, it provides taxes, but we should be able to reach out, and it's just a thought, but to their EDC, to the county judges, and ask them, we're about to grant this, and you guys may want to come in and match or help us with this company to lure them to Texas. Because what I've seen from the governor's office and Dan Patrick's office is that everybody's trying to bring everything stateside because of what happened with geopolitical and COVID. And we want everything in Texas. Well, this is a great tool for us to increase that. Say we were capped at 20, but I know we're not, but we really wanted to bring more money in. If this is such a good idea, the local municipalities or the counties or EDCs, they would jump on board because it's to their benefit to have that entity there. Because again, it's economic growth. It's a great feather in the cap, and it's a great jobs creations and more taxes. So I would urge you to consider, I don't think it's prohibited, but I think we should research that every time we do these type of grants, once we're ready, that we should reach out to these entities and tell them, by the way, Denton County, Dallas, Houston, wherever it is, we're about to do this. You might want to come in and help this company X expand. And then the other thing is, I want to be sure that when we award this money, and I've said it before, is that I'm not interested in a 2,000 square foot facility or have an office with a little tag says CEO there, right? I'm expecting them to bring their infrastructure in. Now, I understand they're not going to move the entire thing there, but It's got to be meaningful. And I hope we're kind of sorting that out because we don't want, at least I don't want somebody to get, say, $20 million and all they have is a little room like this.
Yeah.
I mean, that's not the intent.
Right.
Right. So I'm hoping, and I'm sure you guys are far more intelligent than I am, sorting those details out.
No, and it's an interesting thing because we get a lot, Priya and I talk to a lot of companies and they're looking to relocate. We spend a
Sure.
lot of time telling them, you know, it's not just, you know, hanging a sign up there. It's, you got to be in Texas. And we're looking for, you know, again, like we started out, the goal isn't necessarily economic here, but that certainly isn't a bad side effect, right? And so we certainly.
Now with the
want-
legislature telling you, you know, you CPRIT, you're not making money.
Yeah.
Well, that's fine.
Right.
We're going to help
And
you.
dovetail with that, a couple of
Yes.
different things. One, your suggestions, and I appreciate that.
Mhm.
We are trying to work with like venture money and other people, because even if they don't get CPRIT funding, we want them to get funded and then we want them to be in Texas because that's a benefit to everybody too. Even if it doesn't come from CPRIT, if we can, like, you know, Tracy Davies and Wayne working on our page, put together this big white paper now. We have these connections now so that if CPRIT can't fund them, you know, maybe someone else can. We can give
That's
them,
right.
you know, recommendations to go to these different.
But that's what I'm telling you, Ken, like, for instance, I know Mayor DeMarco, he deals with this. They want to help. The EDC, the municipalities, the counties,
Okay.
it is in their best interest to have them in their community. They want to help. Don't worry about the venture capitalists. That's fine if they come along with it. But it isn't, and that's why Tesla's here, right? I mean, they didn't come because it's
Right.
great. I mean, I'm sure the state of Texas is great, but they got a lot of incentives.
Yeah.
And it wasn't from CPRIT or anybody else. It was from those municipalities and counties. The same thing applies. I'm just saying, you should look into that other tool to help you bring that into Texas. That's all.
That's a good idea. Thank you.
Mhm.
All right, where was I? Wayne?
You're
Clicker.
telling Wayne to make the next slide.
Okay, so one of the other things, again, and we don't need to spend a lot of time on this, but one of the other ways too, to like kind of, we had so many companies that perhaps, you know, as I said, through the preliminary review, 50% got through. So perhaps we need to, I don't know if artificially, but we might need to ratchet down that percentage that actually get to full application so that we're not having to look at 20 or 25 applications at any point in time. So next one. All right, so this quickly, we've kind of addressed some of these, you know, we want to continue to expand our reviewer pool, which will increase our expertise as well as increase the number of companies that we can look at for full application. I think we want to increase the number of devices, diagnostics, and new technologies. And again, going back to the revenue aspect of that, one of the things that Wayne talked about earlier on is on the therapeutic side of it, you know, you're talking 10, 12, 15 years to come to fruition. With devices and diagnostics, with a 510K or PMA, maybe you can do it within 3 to 5 years. And even with like some of the bioinformatics or biomanufacturing, you may need a lesser level of FDA or government scrutiny or regulation and actually get the market much quicker. The margins may be smaller, but actually you can get the market quicker. So those are some of the things that we're thinking about. And then the final thing that's not up there, which, you know, obviously we need the OC involved in, and as well as the PDAC and the PDRC is portfolio management. One of the things that the goals of the product development is to look at all the companies we have now and drill down and get the statistics necessary to say, okay, we're mature enough now. What should we be funding going forward? You know, what areas are we underfunded in, or is there a mix that might be, you know, optimal for CPRIT? So, and that's it. Thank you. Nice job. Appreciate that.
Yeah.
I guess the only other thing left is the RFAs. The RFAs, as I said before, we introduced them at the beginning. Those RFAs will not substantively change for 2024. So they'll still be therapeutic, device and diagnostics, new technologies, and seed. So.
Mr. Mayor.
To follow on what Dr. Hernandez said, I guess the point would be at the time we are approving, and I don't think we need a cap. We've got a built-in cap anyway with the limitations on the dollar. So, I mean, so you really have a cap. But at the time we approve, and this is something tied into the legislature, then they would have to go after potentially local dollars if they're going to relocate or whatever in there, which I agree with Dr. Hernandez. That's an idea to
Yeah.
piggyback and complement what we're doing. However, the legislature stopped 381s or whatever it was this last year under the comptroller. So that we could, when we talk, we might want to talk about the companies we're bringing in and the importance of continuing certain incentives, allowing the local communities to participate. Just an idea.
Yeah.
Okay.
Excellent. Yeah, thanks.
Thank you for that presentation, Dr. Smith. If there are no further questions, members, I will entertain a motion approving the proposed fiscal year 2024 RFAs as presented by Dr. Smith.
So moved.
Second.
All in favor, vote aye.
Aye.
Any None, motion carries. Thank you, Dr.
Thank you.
Smith. Appreciate it. We're going to wait to take up agenda item 10 until later in the meeting. Moving on to agenda item 11, the chair recognizes Mr. Roberts to
Thank-
present his appointments to the Scientific Research and Prevention Program Committees.
Thank you, Dr. Patel. I appointed 6 experts to our peer review stable. Our statute requires the Oversight Committee to approve these appointments. At their February 2nd meeting, the Board Governance Subcommittee reviewed the appointees and recommends approval by the Oversight Committee. I request your approval.
Sorry. Are there any questions for Mr. Roberts or the Board of Governance Subcommittee? Hearing none, is there a motion to approve the CEO's 6 appointments to the Scientific Research and Prevention Program Committees?
So moved.
Second.
Any opposed? All in favor? Aye.
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 Motion carries. Turning to agenda item 12, I recognize Mr. Roberts to present the presiding officer's new appointments to the Prevention Advisory Committee.
Right, thank you, sir. Again, the Board Governance Subcommittee on February 2nd reviewed Dr. Patel's proposed appointments to the Advisory Committee on Childhood Cancers and Product Development Advisory Committee. The subcommittee recommends that you approve these appointments, and I request your approval. Dr. Patel requests your approval.
Yes, please. Are there any questions for Mr. Roberts?
Do we select people with 6 syllables in their names? Just
And
kidding.
this is why we call him Atul. And
And not
we've worked,
Dr.
we've worked with Atul in many capacities, so. And we've worked with Mr. Bouchon as well, so.
That's coming from a person who's entirely monosyllabic. But that's perfectly fine.
I know some of us, yeah.
No vowels.
No vowels there. Is there a motion to approve the 2 advisory committee appointments?
So moved.
Second.
All in favor, vote aye.
Aye.
Any opposed? Hearing none, motion carries. Members, the next presentations will be from 2 of the Oversight Committee's advisory committees. CPRIT provided the advisory committee reports prior to the meeting, and I hope you've had the chance to review them. From a time management perspective, we expect each presentation and question and answer period to take approximately 30 minutes. Dr. LeBeau, please introduce Dr. Gorlick, who will be joining us via Zoom to provide the Advisory Committee on Childhood Cancers annual report.
Thank you, Dr. Patel. I am delighted to introduce Dr. Richard Gorlick, who is the Division Head and Department Chair of Pediatrics at the University of Texas MD Anderson Cancer Center. Dr. Gorlick is also the Grant Taylor MD, W.W. Sutau MD, and Margaret P. Sullivan MD, Distinguished Chair in Pediatrics and Interim Chair of Sarcoma Medical Oncology. Dr. Gorlick is extremely accomplished. For more than 2 decades, his research and clinical efforts have concentrated on sarcomas. As the director of the Pediatric Sarcoma Research Laboratory Program at MD Anderson, his lab focuses on targeted therapies, new drugs for childhood cancers, and understanding the mechanisms behind the development and progression of bone cancer. He's published over 315 peer-reviewed papers, reviews, and book chapters, and served as an active member, advisor, and leader in many organizations, including the National Cancer Institute's Pediatric Preclinical Testing Consortium, the Sarcoma Alliance for Research Through Collaboration Consortium, and the Children's Oncology Group. Dr. Gorlick has also been a highly effective leader of CPRIT's Advisory Committee on Childhood Cancer. And I'd like to thank him both for his leadership and for joining us today to give us an update on the activities of this committee. Dr. Gorlick?
Thank you, Dr. LeBeau, for that very kind introduction. Thank you, Dr. Patel, and members of the CPRIT Oversight Committee for allowing me the opportunity to present on behalf of the Advisory Committee on Childhood Cancer, which I have the honor to lead. As I start this talk, I'm going to reveal to you that the slides that you may have been provided in advance are going to be more extensive than the slides I'm actually going to present today, largely to accommodate the time for this presentation. So today I'm going to give a very brief presentation around the summarizing childhood cancer, talk a little bit about the CPRIT pediatric achievements, talk about the recent steps by the advisory committee, talk about the strategy that's forming, and summarize and suggest some next steps. So childhood cancer is the leading cause of childhood death from disease. If you take the United States, there's about 14,000 cases, with about 1 in 330 Americans developing cancer before age 20. Texas, concordant with its population, has the second largest population by state of children with cancer in the United States. Cancer survivorship, because of their chronic medical issues, are a growing issue. And we have many malignancies where the cure rates have improved dramatically, but others where more effective treatments are needed. The prognosis remains quite poor, unfortunately. When we think about childhood cancer, I want to extend a little bit how you think about it. And I want you to begin to think about it as including as well adolescents and young adults. Adolescents and young adults are individuals who fall in the cracks between pediatric and medical care and are recognized nationally as a group that has unique challenges both by their age and healthcare delivery systems. Adolescents and young adults are much more common than children with cancer. There's 90,000 each year diagnosed with cancer in the US, and 10% of them are diagnosed in Texas. And again, these are groups that have areas with improvement, but areas where things continue to need improvement. Texas, with its large population, is uniquely positioned to be a leader in this area. I want to highlight that Texas, we have to think about not entirely homogeneously. If we look at the healthcare regions in the state of Texas, there's slight variability in incidence across the state. And there's also differences in survival across the state. And I'm going to come back to this as we talk about strategy overall. So briefly summarizing, we need to improve survival and outcomes. We have a large patient population, which becomes bigger if you include AYAs. But we have variability across the state, and we need improvements in outcome, both globally as well as in specific areas. So I really want to start by saying CPRIT has really already demonstrated a tremendous commitment to childhood cancer, which we obviously believe is really appropriate and appreciate. I'm highlighting selected projects throughout the state, but the reality of it is there's tremendous support through individual research awards that are devoted to this as a topic. Core facilities have been a huge organizing principle for pediatric cancer across the state. And what CPRIT has provided is the opportunity for institutions to apply for an additional core if it focuses in the pediatric area. And this has been critically important to the success of the research enterprise in pediatrics throughout the state. And this is something that continues to be ongoing. and I truly applaud. Again, pediatric investigators are part of recruitment efforts, and wonderful individuals have been recruited to multiple sites, and again, are a key part of what's already happening. And I really have to thank the leadership of CPRIT, as well as the Oversight Committee, for their engagement in this topic. The group has joined our advisory committee meetings, our in-person meetings, and have really been tremendous advocates for pediatric cancer. And I thank them greatly for that. So what are some of the things the advisory committee is doing? One of the things that we did early on when I took over leadership of the group is we expanded the representation markedly in terms of the number of people who both formally are part of the committee as well as informally report to it. Some of the things we wanted to accomplish is to make sure we had a critical mass of investigators throughout Texas who led different areas of critical importance to CPRIT. I want to highlight that one of the group focuses specifically on adolescent and young adult. And I want to also focus on Frontiers. So Frontiers was the name they selected, but it's the group that's trying to ensure that CPRIT benefits all of Texas. These are folks who are predominantly based at smaller institutions, trying to make sure that we get the impact distributed throughout the state. So another thanks I have to give out is really the Carson Leslie Foundation. So Annette Leslie, who leads it, is a tireless advocate on behalf of childhood cancer and specifically brain tumors. Her support was critical in a regular meeting called the Researchers Roundup, which once again happened in Dallas this past year. It was supported by other groups, other philanthropic organizations who also supported us getting together with this a critical step in coming to some of the strategies I'm going to present. So what are some of the strategies? One, I don't want to minimize the importance of the pediatric awards that have already been sort of given out and the pediatric specific call for individual research awards and for core facilities. These have completely been transformational in how research occurs throughout the state of Texas. And these things we all highly support continuing. Then from there, we realized that the things that have already been funded, we can do things that are relatively simple that can multiply their effect. And, some of this is just enhancing, web dissemination of the core services, as well as making them more available for utilization. We have a lot of expertise around preclinical testing and early steps in drug development, which clearly can interface with product development, other things. And it's a matter of organizing that better so it's more effectively utilized. With new members, we are looking forward to helping with that. Improved data harmonization and sharing, and really just sort of aligning some of the individual RFAs to a greater extent with the use of cores so that we can maximize the synergies and make sure we're using this most effectively. And we can use publications as a means of sort of disseminating the call to do this so that some of this can just happen with the support of institutions that are part of this. And then we started to get at, what are the problems we need to tackle in childhood cancer? And the problems that we need to tackle include that, the pediatric population throughout the state isn't very well defined. So if I start looking at parts of Western Texas and Southern Texas, I'm not even really sure at what institutions the patients are receiving their care. It's likely that many drive great distances, many may be cared for in private practices. And if we think about this for children, it expands even more for adolescents and young adults, where we don't have a really good sense where these patients are receiving their care. I did show the variation in incidence across Texas, and we don't really understand why that is. And, you know, environmental exposures, demographic details, things that may explain it, we don't even have capture to begin to test hypothesis. In many sites, challenges, there's a lack of critical infrastructure. Like they don't provide their information regularly to registries, they don't collect biological materials, they don't participate in clinical trials. And some of this may actually be exacerbated just by the fact that we don't have as many pediatric cancer-focused population scientists and implementation scientists as we would like. Indeed, at the Researchers Roundup, we had somebody who focuses on the medical oncology world presenting about implementation science, largely because there wasn't pediatric representation in that area. So some of the things we thought about were considering designing RFPs that would enhance, you know, ways of sort of including patients throughout the state of Texas. Some of those would be through population-based studies. Some would be studying defined subgroups, you know, AYAs, patients in, you know, without access to large institutions. We would utilize implementation science to maximize their engagement. We would try to provide interventions as part of this, expand the reach via technology, including underserved populations, with a lot of the goal being providing services like genetic counseling, like fertility counseling, to places where it's not really necessarily available. These are things routine at large academic centers, but certainly not throughout the state. And again, the goal is to identify the primary, secondary, and tertiary referral patterns, assess clinical trials accrual rate, really getting data on the capabilities so that we really understand what exists to a greater extent, and trying to use that information to improve infrastructure to, you know, get access to the best possible care to all of Texas. So really drilling down, we're hoping folks will consider specifically requesting applications for new researchers focused on childhood cancer topics that are critical needs. Again, continue to develop proposals that focus on all of Texas. Areas of high priority may include in recruitment awards, population scientists and implementation scientists. You know, if folks would consider specifically recruiting for that, we would be very supportive of that. So, you know, critical to pediatrics is really continuing pediatric specific core grants and research grants. We do want to pursue the immediate opportunities that were already outlined. And we really believe as a longer term opportunities, we could utilize the cores along with a new RFP to enhance collaboration across Texas with smaller programs, facilitate data sharing, implement best practices, and provide basically a common infrastructure for pediatric cancer research. And finally, summarizing, thank you very much to Dr. Patel, the Oversight Committee, all of CPRIT leadership, and to be honest, all of the state of Texas for, you know, supporting CPRIT and its commitment to childhood cancer research. CPRIT has really supported remarkable innovation and scientific breakthroughs, and continued support of pediatric targeted proposals we believe remains critical. And just, you know, as a thank you and an acknowledgement, you know, I wasn't going to list all the names of the members of the committee again, but these are some photos from the Researchers Roundup. It shows you many of the CPRIT folks who are actively engaged and active participants at this meeting. Really, that's critically important to, you know, coming to conclusions that we think will best serve the entire state. So thank you to you and thank you to all of them. And I would be happy to take questions, you know, and turn it back to the chair.
Thank you very much, Dr. Kolek, for a wonderful presentation. Yeah. Are there any questions for Dr. Kolek? Yeah.
You know what? Yes,
Please.
Dr. Gorlick, thank you very much. I'm a great admirer of your work. You mentioned the lack of data available on, incidents and distribution and stuff like that. It's the place where we have the most data is in prevention, right? I mean, we gather data and our grantees are required to submit data. Is there any crossover there with on the pediatric side?
Yeah, there is.
In other words, would it be possible to collect data from the prevention grantees that would solve some of the lack of data that you mentioned?
Yeah, that is a great point. Whatever data we have actually is coming through folks aligned with prevention. And I didn't get the credit slides as I went along, but that graph where I showed the state of Texas and the variation in incidence and the variation in survival actually comes from Michael Schur, who leads one of the pediatric cores and is in fact, in the prevention epidemiology sort of space. And the reality of it is the best data comes from the Texas Cancer Registry, which has as much as there is to get. And we have mined it to the extent we can. I still think the fundamental question is really, where do patients in Western Texas and Southern Texas in the pediatric and AYA range get their care? And what can we do to optimize it? And if I sort of ask that question simply, like, where do the patients go by and large? I can't answer the question. And I am guessing the answer is sort of multiple, meaning the institutions in the area, traveling, and in some cases, local providers, who are probably medical oncologists who are spanning into the pediatric space. I am not saying any of those approaches are better or worse. The key is to optimize the care regardless of the setting it's being provided. So if a rural medical oncologist is providing care to peds patients, we want to make sure they have access to, genetic counseling, fertility, things that would be standard in the large academic centers that they may not be thinking about. But our alignment with prevention is outstanding. This is not a matter of not communicating across the groups. We have wonderful epidemiologists in the group. This is a gap in knowledge.
Thank you.
I have a question and a comment.
Dr. Hernandez, please.
Yes. Very nice presentation, Doc. I appreciate it. I can help you answer some of your questions that you have for South Texas. Currently, patients from South Texas, they go to Baylor, they go to MD Anderson, they go to San Antonio out of South Texas. There is a pediatric oncology group in the area. They're COG affiliated as well. Why they're not sharing their data, I'm surprised to hear, because they're from Baylor College of Medicine. I will tell you, you are the leader in this space. And as a leader, you need to set the pace. You need to make sure you set the example for the area. MD Anderson on the adult side is actually in the Rio Grande Valley now building a facility. And I would urge you, if you want those answers, you want to participate, you need to put a footprint, because some of these children are traveling to your institution, and that's quite a distance for them. Some people can afford it rather easily, other families can't. And so you're having all this large population anywhere from El Paso or elsewhere going to you because you're not there. And so if you want participation, you need to build trust and relationships, but you can't do it over the internet. You need to have some footprint in those communities, and they'll welcome you. They want you there. So I would urge you to talk to your colleagues. It's not just about data gathering and using the internet to take care of patients and to collaborate. It's more than that. You need to have a presence and you need to build that relationship. So I would urge you to consider that.
I 100% agree. And I am fully aware that we receive a lot of patients at MD Anderson in the pediatric space from a far distance. I also agree 100% with your statement. The best care is close to home. Putting the burden on a family to travel, 1,000 miles to be far from their families and sort of disrupting their, social network as a need for cancer treatment is not providing sort of the optimal care. And I agree with you totally that the large institutions have to make a commitment to sort of figuring out how to extend the reach of what they're doing. I think the critical part of gathering data is really, I don't think I want to go to my leadership suggesting we move into an area that sort of isn't quite receptive and, doesn't view it in the spirit it's intended as sort of pure outreach and pure, willingness to help. I am aware there's a lot of great institutions sort of spanning Texas, and, we want to sort of, partner rather than, disenfranchise. So, there are wonderful facilities throughout the state, McAllen, Corpus Christi, El Paso, Lubbock, and otherwise. We want to build with them and partner with them, and augment their services, not replace or threaten. Obviously, MD Anderson is taking small steps, slowly. The Children's Cancer Hospital, has opened a presence in League City, trying to explore how you can do it. It's more a matter of, we want to partner. We don't want to threaten. And we want it to be everybody. We want it to be Texas Children's. We want it to be MD Anderson, UT Southwestern, not just MD Anderson taking ownership of the state. And obviously, CPRIT is uniquely poised, with its relationship with every organization to achieve that mission.
Thank you. Any further question? Dr. Korik, thank you for answering that in a very diplomatic way. Appreciate that.
Thank you.
Thank you. I appreciate your presentation and your advisory committee's work. Thank you very much. Ms. Maggot, please introduce Dr. Shokar and Ms. Tillis, who will provide the Prevention Advisory Committee's annual report.
I'm delighted to introduce the Prevention Advisory Committee Chair, Dr. Kiran Shokar, and Vice Chair Sensaria Tillis. They will both be presenting today. Their bios and their presentation can be found behind tab 9, page 50, starting on page 51. Dr. Shokar is Professor and Chair of the Department of Population Health, Associate Dean for Community Affairs, and Co-Lead for Cancer Prevention and Control within the Livestrong Cancer Institutes at Dell Medical School at the University of Texas at Austin. She received her Master of Arts degree from the University of Cambridge and her medical degree from University of Oxford Medical School. She has previously been at UTMB Galveston, Texas, and Texas Tech El Paso. Her research focuses on multi-level clinic and community-based interventions that bridge the divide between public health, the community, and healthcare systems, with the goal of addressing cancer disparities among racial and ethnic minorities and vulnerable populations. Sensaria Tillis serves as the Senior Director, Cancer Support Strategic Partnerships for the American Cancer Society in Texas. She leads a team of health systems account and territory managers responsible for developing partnerships to advance ACS's patient support priorities. This includes implementing clinical and community interventions focused on primary prevention, as well as increasing cancer screening rates, advancing navigation support, and promotion of engagement with the research and advocacy programs. She has led the development and implementation of public health, behavioral health, and community development initiatives in Arizona, Texas, New Mexico, Oklahoma, Kansas, and Missouri throughout her career. I want to especially thank both of them for their leadership to the PAC and their dedication. They've spent countless hours with not a big paycheck to the advisory committee. So I'd like to welcome them to the podium.
Hello, everyone. It's great to be here in person. Thank you for inviting us. I hope you can hear me okay. So yeah, if we could have the slides. So Sensaria and I have been working together for the last year, building on the work that we started The Prevention Advisory Committee is one of the newer advisory committees. We started it just as the pandemic was getting going, which was an interesting time to be beginning this work. So I'm going to start by just going over the member roster. The intent with this roster is to make sure that we reflect the geographic breadth of Texas, different kinds of communities, and making sure that we get representation from different kinds of organizations as well, not just academic organizations where a lot of the programs are based. So we added this last year, Dorothy Gibbons from the Rose, which is a nonprofit in Houston committed to cancer prevention, particularly breast cancer. And we added Rakshanda Raman, who is an oncologist from Lubbock, representing that area of the state. So we've been meeting over the last year to kind of think about what we can really do and how we can really move the needle forward on cancer prevention and really meet the promise of cancer prevention and early detection and all the initiatives we know that work. And there are a couple of initiatives in particular that Sansaria will present on that we've really made some progress on moving forward. Next slide, please. Oh, I have to do it. Okay, sorry. So just to review, I think, okay. So this map of Texas shows the geographic distribution of the prevention program grantees. There are about 69 projects funded at the moment, and this number has been pretty consistent over the last few years. And the great news here is that every single county in Texas has services provided through funding that's being received by CPRIT, through CPRIT. So this is really great. We certainly have the reach across Texas that we want, which is to be able to offer services in all our communities. You can see certain concentrations, the darker colors in orange, where there are multiple projects addressing multiple cancers. The challenge is that although we do have reach in every county in Texas, the services may be limited, or we may not be maximizing how much we're really penetrating into the populations.
Excuse me,
So-
just 1 second. Is that currently we have project, and not historically, but
No, this is right now.
wow.
Yeah.
Thank you.
So we've done a really good job. The mechanisms have really kind of propelled this forward, because in order to continue to receive funding, grantees are really expected to expand their services. So I think that has been a really big success, and it's been very nice to see the evolution from the beginning to this point. But that doesn't mean the work is done. That's the point I was trying to make. Yeah. Yeah, so this is good. This is what we want now. We just need to build on this and galvanize efforts to get to the next level. The other thing I would say while we're kind of on this slide of Texas is that, you know, that there's a lot of parallels in some of the points that Dr. Gorlick made about how complicated it is to be able to provide services across the state, how complicated it is to really understand how we can really move the needle when patients are seeking care and preventive services in such different settings. And considerable numbers of our population, of course, don't have access to care. And how do we reach those? So the CPRIT prevention program grantees are really focused on that population and have been very creative and resourceful in building programs that provide services to populations like that. So in order to get to the next level, though, we really need to galvanize efforts across all the different settings where prevention services are provided. And a lot of them are primary care, and they may be in academic health centers, they may be in county health programs, they may be in federally qualified health centers, or they may be in private practices that physicians have. So it's really a big task to think about, how do you coordinate and galvanize such diverse patients being seen in such diverse settings, and how do you really move the needle to the next step? Because we made great strides, but we still have a lot of work to do. So the kind of people that do this work on the prevention program side are scientists, but they're not the scientists that go into the labs. They're the implementation scientists who are really thinking about, well, how we translate the knowledge we already have how do we help that knowledge to get deployed to the patients and the communities where it's needed? Because there's still a big gap. There's a lot we know. Half, the kind of for screening detectable cancers, half the cancers are those kind, the top cancers. We know how to prevent them. So we can really make a massive impact if we could just figure out how to do this. And it's complicated, right? Because there are regional variations in services delivery. There are regional variations in even the incidence of mortality from cancer, just like Dr. Gorlick was describing for childhood cancers. So it's a very complicated problem, and the solution is going to be very complicated as well. But that doesn't mean we can't do it. We can do it. And this is what the Prevention Advisory Committee has really been thinking about over the last year and before as well.
Excuse me, Doc, I have a quick question for you. Do you have anybody from the private sector involved in helping you do this collaboration besides academia? Is there anybody else? Do you involve any private sector entities?
So we do have, so you mean private clinics and
Private
things
clinic,
like that?
private health systems,
So
anybody?
are you talking about the Prevention Advisory Committee or program
Actually, both.
grantees? Okay, so the grantees are really resourceful, and they often do. I mean, I can speak to my own experience, how in West Texas and El Paso, we really worked with the for-profit hospital systems as
Okay.
well to try and get services out to their populations. So the big thing about CPRIT is the grantees really focus on the uninsured, underinsured, and those populations. But in order to really impact prevention across the state, you do have to focus on that population. But what you do there is might be quite different to what you do for the population that's served by the private hospitals. But in order to move the needle on prevention and really reach the promise of prevention, you do have to work across both groups, because, our work in El Paso really kind of highlighted that many of the challenges we have for vulnerable populations in terms of the way the systems are organized, availability of data and things like that, there also exist on the private side. So your point is really well taken. There are a lot of shared barriers and shared solutions that we could deploy across those population
But do you
groups.
work with health districts or the
Yes.
indigent care programs of the counties that
Yes.
throughout the state? Are they helping you guys out?
Yes, so
Okay, great.
yes, that's a very important partnership that many of the program grantees have. So certainly in the programs I've worked with, we've had that, and others as well.
Great,
So
thank you.
yeah. So I think that one thing I would say as well, while we're on this slide, is that the points Dr. Gorlick made about implementation scientists, population health scientists, are really well taken, and they're very applicable on the prevention side as well as on the childhood cancer treatment side. So I think that's a really important priority, and one that we also highlighted. Okay, next slide. Oh, it's me, sorry. Oh, you want me to do it? Let me do it. Okay, so just a summary of the projects, the 69 projects that are still in, that are currently active across every single county in Texas. I don't know how well you can see on here, but they're organized by cancer type. So you can see that HPV related cancer services, colorectal cancer, tobacco related services are the most frequently addressed. Now, many grants address multiple cancers, so they'll combine breast, cervical, colorectal, and so these may be covered by multiple grantees. And some are more focused as well, but generally people leverage the relationships that they have made and the organization of prevention services, and then add in new cancers that they can also provide services for, so which is a very efficient use of services. And then you can see that the majority of the cancer grants on the prevention side are for screening and early detection. There's also some survivorship and vaccination also counts as prevention, but survivorship and tobacco cessation and healthy eating, living are also addressed. And this last year, there was a new RFA that was produced, which separated out secondary prevention, which is screening, from primary prevention, which is tobacco cessation, vaccinations to prevent cancers in the first place, as well as obesity-related work. So here you can see numbers of services provided by the grantees. And you can see that colorectal cancer screening services are the most frequently provided, followed by cervical cancer, and then hepatitis B vaccination and hepatitis C screening, and then followed by tobacco cessation and HP vaccination on the prevention side and breast cancer screening on the screening side. No, it's random. So there's an open call for all cancers. Sometimes there are more targeted ones, like there was one for liver cancer a few years ago, but generally it's open. So people pick, the submitter decides what they're going to address. So these are active grants by mechanism. So you can see that the most commonest is the screening diagnostics, followed by expansion of the screening grants, where, the RFA really encourages current grantees to think about how they can expand either the cancers they offer or the geographical area that they're offering services. And then there's, you can see the tobacco cessation and the dissemination grants as well on this one. So I'm gonna hand it off to Sansaria here.
Hello, good morning. I believe it's, still morning. Hello, everyone. I'm pleased to just share a quick update on our current activities. Like Dr. Shokar said, there's lots of great things that the Prevention Advisory Committee has actually taken up and ran with, and we have some accomplishments under our belt at this point. So the first thing I'm preach to the choir just a little bit here related to colorectal cancer screening. Colorectal cancer is the third most commonly diagnosed, frequently diagnosed cancer among both men and women in Texas. There's a little bit, almost 12,500 people that we estimate will be diagnosed with colorectal cancer in 2022 or who were diagnosed in 2022. And so we have prioritized colorectal cancer. I think Dr. Shokar talked about screenable cancers. Colorectal cancer, of course, is one where we can actually prevent it through screening. And so a lot of the CPRIT grantees have been really focused on building best practices and evidence-based work across the state for some time related to colorectal cancer screening. And so one of the things that we prioritized, which was discussed before, was the establishment of a statewide coordinating center. We just talked about how complex Texas is and how vast it is, and all of the different partners and the feast and the famine that is healthcare across our state. And so the idea of this RFA is really to bring together a hub for both resources, data, as well as education outreach, and then technical assistance, not just technical assistance to the community, but technical assistance to smaller organizations and clinics around evidence-based practice. A lot of what we know in terms of evidence-based interventions to increase screening rates, it's been there are some real proven, almost shovel-ready projects that exist. It's just about getting them disseminated and implemented. And so the idea of the coordinating center is really to help take that charge for the state and help to support that for the state and be that central hub and repository. So those applications have gone out. We expect them to come in, I think they may be due now, but soon enough we will have, unless for whatever reason that one is not funded and supported, we will be having the first statewide coordinating center. And again, we want to, if this works, we want to look at replicating this concept for other screenable cancers and priorities that CPRIT has on the prevention side. And so the next item, is kind of related to the first, because what we recognize, the American Cancer Society particularly recognizes that we're going to create some downstream challenges the more we're driving up screening in the state, particularly amongst uninsured patients, Recognizing that lots of those people don't have coverage, we can screen them and diagnose them with cancer through these CPRIT prevention projects. But there is not a source for many patients in the state of Texas who might get diagnosed with colorectal cancer for treatment. And so advocates who are part of the committee, along with the American Cancer Society, one of the things that we're proposing is a general revenue appropriation of $20 million to support cancer treatment for uninsured patients, patients that are the working poor who do not have access to treatment, because we are going to run into a big challenge here the more we driving up the screening rates amongst these communities. And it's so advocates from the committee, along with the American Cancer Society, have put together a proposal, and we would like to see a general revenue appropriation for cancer treatment services to be administered not by CPRIT, but by the Health and Human Services Commission. We have currently, there is an existing program that this concept is modeled on, which is the Texas Breast and Cervical Cancer Treatment Program. So very similar eligibility process, but would provide and alleviate some of the challenge we're going to face potentially in uncompensated care by diagnosing more cancers amongst folks who do not have coverage for treatment. So that's an initiative that has sort of spurred out of a lot of what we've discussed on the committee. We have the support of the Texas Society of Gastroenterology and Endoscopy. They've endorsed the initiative, and they will be helping to support promoting it. And that the members of our committee have also shared it with their government relations teams. So we are, we're looking at all ends, and we definitely want to make sure Texans are covered and taken care of. So happy to answer any questions about that. And then the other thing, lastly here, that I want to share about our current initiatives is we have an assessment underway. It is about a year into the process. We expect within another year or so we'll have the results of the prevention program assessment. There was a grant that went out to support that. Data collection's underway, we're conducting interviews with the program directors for all the grantees, as well as collaborators. So I think we'll get some feedback from some of the partners on how the CPRIT prevention program has impacted their communities more so than what we know now. So looking forward to that. So I'm going to turn it back over to Dr. Shokar to talk a little bit about our recommendations going forward.
Yeah, and I just want to say that last initiative, the prevention program assessment, was a recommendation from the Prevention Advisory Committee that became an RFA that was submitted. And so the grantees are working on that project. So let's move on here. So as we've been considering over the last year, the Prevention Advisory Committee has met to discuss, what do we need to be doing? What can CPRIT do in this space to really galvanize efforts for prevention? So one of the things that a theme that is very frequently coming up in our conversations, and also mentioned by Dr. Gorlick, is how do we accelerate research and capacity in prevention and control research? So this will require collaboration with the academic program side. And really it's about also gathering more information and a deeper understanding of what our capacity is at the moment, and understanding from the academic program side as well, the grants that are given out that are more prevention focused or applied research focused on the health services side. So what we'd like to do is to see some RFAs that are really specifically focused on fostering research that involve the skills and approaches that are really needed to make an impact at the population level. So these are things like community-based research methods experts, health services research, which is how we deliver care and how we get it to the people that really need the care on the prevention side. And again, with dissemination and implementation, some of the best practices that we already know, how do we facilitate their deployment into routine care by physicians or other providers, public health experts throughout the state. And of course, looking at the cost effectiveness side as well to understand what impact we're really having on future costs and current costs as well. And then, we
I have a question for you. This actually reminds me of the health plans and dealing with insurances, because a lot of times it's not the provider, right? They're following either Humanas or they're following some other provider, Blue Cross. This is their strategy to treat a certain disease. And this is really nice. I'm just wondering, how are you gonna, I wish you could, but I'm about to say, how are you gonna impact the health plans? A school district or a county, because they all matter, right? In the state of Texas, to get them to do, the WellMeds of the world. How do we get them to do this? Because it'd be great for the population as a whole, right? Not just the uninsured or the high risk, but everybody to be on the same page of what you guys are trying to do. Have you thought about how you would work with health plans?
Sure, yeah, and you'll see a recommendation coming on at the end, which kind of speaks a little bit to how we engage with and encourage engagement with multiple stakeholders that are not traditionally part of this conversation, because we focus on a different population. So yeah, it's very important. And they're interested in that too. There's a lot of, they have metrics that are specifically about prevention and screening. HEDIS measures are just an example. So they're thinking about this as well. Okay, so the other thing that we can really, a resource that we have is all the data that's been collected by prevention program grantees, current and past as well. So we could be thinking about how do we tap into that data? That data is not generally shared. Each grantee produces a progress report for CPRIT, which is very standardized. But there's a lot of data behind that as well that could really enhance our understanding about how to reach and be successful with different populations. And there's pre-existing data in the state as well, the Medicaid database. There's an all claims database, the payer database that's going to come online soon. So having RFAs that really specifically focus and target those kinds of research as well. And then, speaking of those mechanisms right now, the mechanisms on the academic program side for research are large, and so maybe out of the scope for everyone, particularly, non-traditional investigators and others that are not supported in academic settings. If we could have small grants or research supplements for prevention program grantees so that they could do some of this work alongside the work that's already happening, and that different kinds of investigators or people just interested in the data could kind of use that mechanism, which is more feasible for them to develop and submit and all the other stuff that goes along with grant making. So that might be something that could really help in this space. And then, of course, we're going back to the data again. The prevention programs have a lot of data, current and past. So thinking about an RFA to really integrate all that data and how to harmonize that data across different grantees. And there's a lot of learning to be had because those grantees have really focused on different geographic areas and communities, and they have the level of data not going to find in a Texas Cancer Registry. So supporting that a center or someone who knows how to do that, some entity with the expertise to really think about that data and how we can kind of leverage that data that CPRIT dollars have already been used to create and take it to usable formats that we could learn even more from. And then increasing capacity. So there aren't a lot of experts they're beginning to be more, but in these kinds of population-based approaches, community-based approaches, and knowledgeable about implementation and dissemination so that we can really increase the delivery of the kind of prevention services that are going to have an impact on Texans. And then so training programs to build those, and then investigator awards for junior scientists so that we really kind of reel them in and get them interested in prevention and these kinds of programs. And, these are K award types or training programs. American Cancer Society used to have a mechanism that was used a lot by people that were interested in this kind of work. They tend to be primary care focused because, they're paying attention to prevention and kind of the nuts and bolts things that have to happen for patients to, prevent cancers. So that's another opportunity, I think. And then, is this the last slide? The next recommendation is about facilitating the development of other statewide cancer screening RFAs, but also taking a step back and just looking at prevention as a whole. What tends to happen is people focus on 1 or 2 cancers or 1 or 2 populations. So you get this very piecemeal approach, but it's really, we have an opportunity here with the resources and funding that CPRIT's able to provide to really bring different stakeholders to the group, that aren't really at the table right now in a meaningful way. So payers, healthcare provider groups, community organizations, public health, academic institutions, as well as current and former CPRIT grantees to really kind of think about the whole prevention space, because the infrastructure for prevention, screening in particular, is very similar across cancers, although the work is very unique. So how do we leverage those? And there are alignments that are possible. Payers are very interested in getting measures from their providers about how they're doing on breast cancer screening, how they're doing on colorectal cancer screening. So I think there's potential alignment there, but until you start talking, building trust and doing that hard work of creating those communities, you're not going to be able to do that. And CPRIT could really have a really great convening role in bringing all those groups together. And then, synthesize, looking at the data to identify priorities and gaps and potential opportunities across those organizations that kind of touch this space. And then, of course, disseminate the findings that and the great work that's happening through CPRIT funding as well is really important as well. So some ways we could do that is, having a cancer prevention symposium, RFA, or something like that to bring different groups together, and also leveraging partnerships to stretch CPRIT dollars, which was also mentioned by the previous speaker. How can we be creative and resourceful to leverage the funding that CPRIT puts onto the table to match and kind of increase the impact even further? How are we allowed to do that, and how might we do that? So there's just some ideas that we had as a committee. And then the last slide, I'm going to hand off to Sansaria.
Yeah, so in the same spirit of galvanizing and coordinating what already exists, this is sort of almost an administrative task, but we feel that there's a very strong need to pull together a lot of the resources that are available. And our thoughts are that potentially CPRIT has an existing materials repository, then that could be expanded to also include links to lots of the work that's happening across the state, and just as a central hub for information for, these young investigators we're talking about investing in, existing programs to go in and review resources and have access to it. The cancer registry, national data, CDC, obviously. And the other thing that we would really like to work on is a mapping tool beyond some of the maps that we have here, but like a GIS analysis tool where we can take a look at a lot of the resources across the state and layer them, the prevention resources, and then also diagnostic treatment, the different programs that are happening across the state to understand where the gaps are. Again, just like, we need to bring all the partners and players together. When we do that, then how do we just capture that information? And of course, anytime you develop any sort of repository or database or anything like that, you need maintenance. So we need to figure out a mechanism for ongoing maintenance and updating of all of that information if we do that. And then just like I mentioned before with the colorectal cancer statewide coordinating center, we'd really like to see that go beyond colorectal. And so in order to identify the next area of a focus, we need to look at using a data-based approach in order to prioritize which cancer screening or prevention area of focus should be for that next coordinating center. And that doesn't just include incidence or mortality rates, but also what is the existing infrastructure across the state to support and help build that coordinating center. So that's one of our next activities, to start that conversation and to do that analysis in order to move that forward. And then lastly, there is a Texas Cancer Plan, and it will need to be updated. Will be updated beginning this year. And we want to be sure that that plan doesn't happen in isolation. Of course, CPRIT is now charged with updating that plan. It wasn't always the case, but CPRIT will be updating that plan. And so we want to make sure that all of this is integrated into the Texas Cancer Plan, because the Texas Cancer Plan is not solely focused on the populations that we primarily prioritize within the prevention grants, but it is supposed to be an inclusive plan for all of Texans, including those who are covered and have health insurance, who also need to get their screening, vaccination, and healthy behaviors for prevention up. So that is also something that's very important to the committee to prioritize. So with that, this is the last slide. I don't know how to get to it, but what questions do you have?
Mr. Margot?
Heidi, don't we pay for part of the cancer registry out of our budget? Yeah. What, we pay for all of it.
It seems like it.
But we pay a significant portion, right?
Well, we did 2.1 million over, and then they have federal funds.
But we've never exercised any oversight on that, have we?
Yeah, they're under the state.
State health services, we can't recommend to state health services to do some of what they're suggesting here in the way of better data. Isn't that what y'all are suggesting?
Their data is designed for a different purpose. So their data.
So it doesn't help.
So for prevention, we can learn something from it. But it's more on the treatment side. So once someone gets diagnosed, it's the data about their clinical care after they're diagnosed. And it's very specific information that's standardized across the whole of the US. So they could collect other information, but that's how that goes. So that's very important for understanding treatment and kind of understanding what the differences might be across the state for treatment. But it doesn't help in everything that happens before someone is diagnosed.
Okay, I thought you all were saying we needed more information from the registry on some of this.
I think we would link the resources of the registry to this repository we're discussing.
Okay.
Could I just ask a question? I'd like the recommendations. I like your identification of the issues that are going on. But how long do you think it will take to operationalize this? I'm an operationals person. I like to go for it. And if one is going to go for it, will your advisory committee put out a plan, precisely a plan in a multi-year process to let us know how you will achieve it? Because this does not look like a project which is going to occur in the next year or 2 years.
No, I think it's a long-term plan, and it has a plan. It has to be a plan that's maintained forever. But so we would take a stepwise approach. The committee can certainly start thinking about what the steps might be. Engagement would be the first step, understanding the data and where the points, where the kind of where the easy pickings are for where we could make an impact really quickly. So prioritization, yeah. But this is a long-term plan. It's, it took us however many years to get to this point. It's going to take a lot more to figure this out. And there's a lot of jurisdictions and stakeholders with different priorities and resources and challenges. So it's never going to be perfect. It's always going to be a working process.
Right. And I quite agree with you. Everything is dynamic. It's continually moving according to the databases that you get. But if one does not have it on paper, then the institutional memory will be lost, and we will be repeating this once again in 10 years' time. And all your advisory committee's great work would be lost. My question is, how are you going to put it down in such a way that the succeeding generations, as somebody said earlier on, we're not immortal, is that that your great work continues and adds, and people can add to it rather than detract from it or repeat.
Well, I think that'll always be a challenge, but I do think what we talked about with the integration into the Texas Cancer Plan, and, obviously that it's not a plan that's just sitting on a shelf, but that is actionable. But that'll be, the duty of all of us, not just who are on the Prevention Advisory Committee, but all of us who have a stake in this work to keep that alive and continue that work. But that's sort of that rationale in terms of integrating, being sure that we are integrating a lot of these recommendations into that plan so that it gets legs.
Thank you. And Dr. Shoker,
I have a,
I'm
I
so
have a
glad
comment.
that you left Cambridge to come to Oxford. Yeah,
Yeah.
that provincial college. Well,
Well, I'm excited about this. I think I'm more excited than you are. I see a lot of potential here, a lot of potential. I think we need to talk after this because I foresee already that the self-insured clients, all the school districts, the cities, municipalities, everybody's going to want to have a piece of this because you're an independent party and you have the best interest of the patients at the end of the day. Insurance carriers they do a great job, but their income generating, and that's their stockholders, that's not you. You want to be sure that you increase prevention and early diagnosis. And and for us, it's in our best interest as well. On the other side of the fence, if we're involved with, say, a school district or what have you, because if I can save lives, that's great. But also, if I can save money in my budget, that's even better. And when I negotiate with my insurance companies every year, I'm getting a better deal every time, and I can actually have more revenue to help out my other school teachers or my other employees. So this has a lot of great potential, and you can have a lot more interest than you think. So I applaud you, and I would put this in overdrive.
thank you very much. I appreciate your presentations.
Thank you.
Well, turning to agenda item 13, the chair recognizes Ms. McConnell to present the CEO's report. Ms. McConnell?
Good morning. You have my report under tab 10. I'll just highlight a couple of things before I move on to the conference update. But in terms of revenue, CPRIT received a little bit over $100,000 in revenue sharing payments in the first quarter. And just to update a little bit more, since then, actually at the beginning of February, we received a check for about $1 million plus from Merck that included both a $942,000 milestone payment for exceeding $100 million in sales. I believe that's correct. Yes, annual net sales of $100 million. So that was the milestone to us, as well as $61,000 from the FY 2022 Q4 royalty payment from them. And just to note on that royalty payment, that now includes sales not only in the United States and Puerto Rico, but also Canada. So it's now being sold internationally. In terms of our debt issuance, we issued $79.5 million in commercial paper notes at the beginning of September for our first quarter tranche. And so total to date that we've issued is about $2.6 billion. And we're about to request an issuance for some additional funds for this quarter as well. Are there any questions before I move on? So on the CPRIT Innovations conference, I think you've gotten to read my update, but since then there's been actually more progress. So the conference website has actually now gone through a soft release. We're going to be announcing it, but you can now see if you go to the texascancerconference.org website that's noted there for the save the date, that you'll see the schedule as well as registration. Registration hasn't opened, but it will shortly. And just to note, we do have our several keynote and plenary speakers, two from the National Cancer Institute, Dr. Doug Lowy and Dr. Robin Vanderpool, as well as Dr. John Carpton, and from the University of Southern California's Keck School of Medicine. And he'll actually be talking about accelerating innovation in cancer population and genomic sciences. In addition, we have several other sessions planned on AI advances in imaging, as well as another on innovations in cancer imaging. There's a computational biology and modeling and drug discovery and development, as well as immunology and vaccine development. And there are also a session planned on biomanufacturing sites in Texas, as well as drug development resources in Texas. Actually, at the end of January, several of us from CPRIT, myself, Shannon Kusick, Mark Leffler, and Justin Rand were planning, along with our meeting planner, Deb Swift, we're planning to go do a site visit at the Moody Gardens Cancer Center, Moody Gardens Hotel and Conference Center. But unfortunately, that was the week then we had the predicted ice event. So we've had to postpone it. We're now planning that to occur March 7th and 8th. So we're getting excited about it. But are there any questions about the conference? Yes, correct.
Have any idea what the projected number of people who will attend?
Yeah, actually, in the past, we've had anywhere from 700 to 800 participants. So we anticipate that. And the majority are generally our grantees. Anything else?
Any other questions for Ms. McCon? Thank you very much. The chair recognizes CPRIT's Communications Director, Mark Loeffler, to update us on CPRIT's activities. Thank you.
Thank you, Mr. Chairman, members. You've got my report there at the end of the packet. And it's probably a little bit of a boring report simply because the last 4 months of my life have been consumed by annual report. So hopefully everyone's gotten a chance to take a look at that. As you've seen, if you have taken a look at it, there's a new interactive tool to see how CPRIT is accomplishing the mission across the state. And I really am very proud of that because it really does give you a very good picture of CPRIT's impact in all corners of the state. And that's something, a message that we're actually talking about today in the press release about today's awards. So hopefully you get to take a look at that. And other than that, I'm happy to answer any questions.
I want to point out one thing on page 11.3. I've got to highlight that Florida continues to lead when it comes to cancer research and patient support. And I love our good friend Andrew Barlow saying, check out CPRIT. I love it. Excuse me.
Thank you very much, Mark.
Quick question.
Please, sorry.
Mark, I just love what you do. You're on
Thank you.
so many media platforms and read all your emails and texts that come every day. So just great
Thank you.
work. I was just wondering if that CPRIT is so important, whether there's any thought about putting up a informational item, say like in the Bullock Museum or the state capitol, as people tour those places, show CPRIT.
I'd love to do that. I'd love to be able to put up some sort of display about CPRIT. Of course, we'd have to find the right venue, but certainly getting information out about CPRIT is the goal.
That's a good idea, Doctor. At least during legislative sessions, and I've got to admit, I haven't walked down there, but this session. But in the basement of the rotunda, there are rotating exhibits, and they frequently have rotating exhibits in the extension. It's too late for this session because those things get booked way in advance, but that's a darn good idea.
At least having a table with informational
I was just thinking there's
materials.
so many tourists that come to.
No,
those
that's a
places
good, that's
Yeah.
a great idea.
From around the state, you know, where they're at.
Great idea.
Absolutely.
And we consider little 30-second testimonials, maybe that in addition to that, that really would.
That we've already got done.
Yeah.
Absolutely.
Thank you.
Thank
Yeah,
you.
follow up. Think through that.
Now, doubling back to take up the internal auditor's report under agenda item 10. The chair recognizes Mr. Graves to present his report. At the conclusion of his report, we will be moving into a closed session to receive an update on the internal audit report over information technology, general controls. Mr. Graves, thank you.
Thank you. I do have just a brief report on the status and update of our internal audit activities. On tab or page 7-1 of your packet, we have our report, our status report. We are in the middle of our contract risk assessment advisory engagement. So this project that we have put together is to help CPRIT comply with the state requirements for contract management and perform a contract risk assessment. So we've built our template and our model that mirrors very much like the model that Vince uses for the contract risk assessment. And we're about to present that next week to management, go over that, and then develop further procedures off of that model once we get feedback from management. Right after that, we'll roll right into the post-award compliance program, where we will actually retouch that matrix that Vince is using for the risk assessment and provide any updates, comments to refresh that tool that is being used. And then in April, we'll begin an audit of purchasing. This will address a lot of the requirements that are in the annual internal audit report over procedures over purchasing. And then IT general controls in the late spring, early summer. Along with on page 7-2 are all our internal follow-ups planned for this year. The first one being performed in conjunction with the IT general controls and information security follow-up over the open findings related to the prior internal audit over information security, and then a follow-up of communications, disaster recovery, and business continuity, and then the vendor contract compliance. So there's a total of 8 findings from those prior reports that we'll follow up on in July. And then all that will be ready and prepared for you in the August meeting along with our annual report. Also attached on page 7.3 and 7.4 is our table summary of findings by year. Probably most interested at what is on page 7-4, the very bottom table is all the open item summary. We put this on 2 pages, so it's a little bit bigger and easier to see. That is it. If you have any questions, I'll be happy to answer those now.
Any questions?
On fiscal year 2021. I'm confused on page 7.3 under fiscal year 2021. Yes, those that are open, those are the ones that we will follow up on this year. The communications, disaster recovery and business continuity. The one on governance is actually completed. We completed it last year.
Thank you.
And we were strong.
If there are no further questions, then the Oversight Committee, thank you, Mr. Graves, I appreciate you. The Oversight Committee will move into closed session to receive an update on the internal audit report over information technology, general controls. Given the sensitive the state governing bodies to meet in closed session to discuss security audits. Once we return from closed session, we will only take up agenda items 18 and 19. For the record, we move into closed session pursuant to Texas Government Code 551.076 to discuss the internal audit regarding information technology, general controls. And the people joining us will be Mr. Roberts, Ms. Doyle, Ms. McConnell, Mr. Burgess, Ms. Eckel, Shannon, Soma Emenike, and Mr. Graves. The time is 11:49. Thank you. Thank you. I am now going to reconvene the board in open session. The time is 12:45. We will not take up standing agenda items 15, 16, or 17. Moving on to agenda item 18, we will meet again at the next regular Oversight Committee meeting on May 17. If there is no
And
further
I'm
business.
going to interrupt you here
Please do.
real quickly. This was obviously our first meeting in this room. I anticipate that further oversight committee meetings will be probably in this room, but are in this building. And there were some unusual circumstances related to this building that our staff had to overcome. And I particularly want to thank Shannon, Kevin, Michael, Melanie, for keeping us going smoothly. It wasn't easy on their part, but thank them.
Yeah. Thank you. Thank you very much. If there is no further business and there is no objection, the chair moves to adjourn this meeting. Is there a second?
Second.
All in favor?
Aye.
Motion carries. This meeting stands adjourned at 12:46.